Welcome to another edition of Rheumatology Highlights Report. This is Dr. Elaine Husney from the Cleveland Clinic. I'm very excited to share with you some highlights regarding the cardiovascular aspects in RA and SLE from the most recent national meeting. As you all know, cardiovascular disease remains a major problem for patients with RA and SLE. And judging by the number of abstracts that we have this year that are increasing from the years before, we are definitely learning more about it. I won't be able to highlight every single abstract from the national meeting, but I certainly will share with you what I think are very pertinent updates. So cardiovascular disease in general in RA and SLE have really remained a major problem for morbidity and mortality. Worldwide, the treatment for rheumatoid arthritis and systemic lupus erythematosus has remarkably improved with the use of targeted therapies. However, survival still remains decreased compared to the general population. And this is in part due to the excess deaths from cardiovascular disease, which we will be talking about today. Cardiovascular risk in patients with RA and SLE, in contrast to the general population, which includes traditional risk factors such as dyslipidemia, diabetes, and hypertension, do not fully explain this excess cardiovascular risk. So we now know that there's both traditional and novel risk factors that may play a role in the accelerated atherosclerosis in these patients. So beyond the known cardiovascular risk factors that I just mentioned, the inflammatory disease, meaning having RA and having SLE, is likely promoting cardiovascular disease through chronic low-grade systemic inflammation and or immune activation. So we're going to start off today with some large cohort studies that have been followed over a long period of years, greater than 9 or 10 years, that help us really wrap our hands around some of these conflicting results regarding the incidence of MI, stroke, and atrial fibrillation in RA patients. So the first abstract that we're going to discuss is titled The Increased Risk of Major Cardiovascular Events in a Nationwide Cohort of RA Patients Treating with Biologics. This is a study out of Denmark using the DanBio registry from 2001 to 2009. Where all patients that were started on a biologic was paired with 10 control population, 10 controls with no RA. They were characterized with respect to their comorbidity, their drugs, and their social economic status, and subsequently monitored for the outcomes of interest, the MI, stroke, and atrial fibrillation, followed until death or December 31st of 2010. So as you see here, the hazard ratios for MI was 95%. Hazard ratio for stroke and AF were not as high, but there was an excess risk in the fully adjusted model. So if you look here, we see that we have 3,872 RA patients and over 38,000 controls that were included, and they were followed for 4.5 years. And here in this first chart to your left shows you the demographics of those with RA and controls. And as I mentioned just earlier, that the hazard ratio in the next chart on your right, looking at MI, stroke, and atrial fibrillation, that there were excess risks. So the conclusion was that the risk of MI was approximately 2 times higher than that of the general population, while the excess risk for stroke and atrial fibrillation was less pronounced. What's interesting about this study is that despite having major treatment, remember I told you all these patients were on a biologic DMARD, that the risk of major cardiovascular events was still increased in this patient population. So if we turn to the next abstract looking at sustained clinical remission, another concept of whether or not this treat to target, so whether or not we take patients and really treat them to sustained clinical remission, do we improve their chances of cardiovascular disease later on? So here we see that there hasn't been much looking at cardiovascular risk in RA patients with low versus high disease activity. And this particular abstract highlighted this important notion to investigate this association between remission and risk of cardiovascular disease. Patients here were followed at 3-month intervals with DOS-28 at each visit. Cardiovascular events included MI, stroke, TIA, angina, and peripheral artery disease. 770 RA patients were selected for this analysis. So as you can see here on the next slide, that there's a time to event curve looking at the cumulative survival of RA patients. And what it shows here is that sustained remission, meaning RA patients who did reach sustained remission, was significantly associated with a reduced excess risk of cardiovascular disease. So this study highlights that maintaining tight control of disease activity in RA patients may help to achieve remission, may be important in the prevention of cardiovascular disease later on. So carrying on the same theme of sustained development of cardiovascular disease in RA patients despite cardioprotective treatment, we're going to look at the CARE study. This is a 10-year prospective study. As you know, we still don't know the mechanisms between cardiovascular disease in RA patients, but here we're looking at a 10-year incident rate of cardiovascular disease, including cardiovascular risk factors and RA, disease-specific related risk factors, and medication use, in a prospective cohort of 353 RA patients. They were looked at baseline, 3 years, and 10 years follow-up, and the association between the changes in RA-related factors and development of cardiovascular diseases were assessed. Their results show that the use of certain medications like antihypertensive statins, including TNF, and general cardiovascular risk increased significantly over time, even though your RA-related factors improved, so even though treatment continued. The analysis showed that the increased use of TNF was positively associated with less incident cardiovascular disease. So if we turn to the next graph, there's a lot of information here with 4 different graphs that you see. But if you look at the bar graph up top, looking at incidence of cardiovascular disease, they're comparing over 10 years those cohorts with no cardiovascular disease and those with cardiovascular disease. And you can see clearly the use of biologics here in this graph here, that those with the use of biologics had a lot less incidence of cardiovascular disease compared to the other group. And in the other graphs, we also looked at disease activities. The authors also looked at HAC as well as the ESR, all pointing in the direction that patients who use TNF inhibitors had a reduction in inflammation and disease as expected, but they were also at less risk of developing cardiovascular disease over time. These were follow-up for 10 years. So the general cardiovascular risk and the use of cardioprotective medications did not attenuate this association. So the more aggressive cardioprotective and sort of anti-inflammatory treatment that we have for RA, the authors summarized might mitigate the burden of cardiovascular disease in RA. Let's turn our attention to the second part of RHR here, looking at RA and SLE disease stratification. So here I highlighted some abstracts that were looking at a patient's ACPA status for RA, looking at genetics, biomarkers, and obesity. So let's start with anti-CCP or ACPA positive autoantibodies. Here we know this abstract started off with a background information that our standardized mortality rates are 3 times higher in patients with RA than the general population. We also know that people with ACPA positive are associated with increased cardiovascular disease in RA. So the thought or the objective of this was to see if ACPA may play a role in altering the structure or function of the heart and therefore maybe can help explain some of the cardiovascular risks that exist in our patients. Their objective was to test the autoreactivity of 17 subsets of ACPA with myocardial function and structure parameters. So they used a Bioplex platform on a Luminex 200 instrument that was used to measure the autoreactivity of the ACPAs. The association of each of these subsets with cardiac MR measures were tested. These patients that have RA, they did not have any known cardiovascular disease. So if you look at this chart here, looking at all the ACPA subsets that you see, what they concluded was that a certain subset of ACPA was associated with decreased left ventricular end diastolic mass. And you can see the different types of cardiac function and structure that they looked at, and you can see by the way of arrows which one increased or decreased these based on the subsets that you see on the left-hand column. So in conclusion, this study did show that there were categories of specific ACPAs that were associated with alterations in cardiac structure. These included decrease in left ventricular end diastolic mass. This also included a decrease in left ventricular mass index. So the authors concluded that identifying specific peptides against anti-CCP reactivity may be important and advance our understanding in the pathophysiology of accelerated cardiovascular disease in RA. Now let's turn our attention to genetics. This is also a very wide area of research right now. We know that LDL is a major risk factor in the general population for cardiovascular disease. However, in RA patients, LDL is actually lower than in the general population, not higher. So despite patients with RA have a higher risk of cardiovascular disease. So the authors here hypothesize what is it about LDL genetic factors that might be associated with pathogenic LDL in RA patients, and whether or not RA genetic factors can influence these LDL levels and perhaps be a mechanism towards poor cardiovascular disease risk in our patients. They had an RA cohort of over 1,800 patients at a large academic center. They created these what they call GRS, which is composite genetic risk scores, and they looked at the association between these risk scores and LDL. They followed these by linear regression models. They made adjustments for age and gender, as well as the baseline LDL measurements. So here we look at this graph looking at mean LDL levels among female RA cases that were grouped by tertiles of LDL and their GRS, the genetic risk scores that I spoke about. So the majority was female, as expected. 68% were ACPA positive with a mean LDL of 119. And they observed that there was an association between LDL genetic risk scores and higher LDL levels. The association was most significant among female RA cases. So here the author's finding provides some sort of genetic link to the epi studies that have been done regarding lower levels of LDL in RA compared to general population. This study demonstrated that LDL genetic factors were significantly associated with higher LDL levels in RA, and RA genetic factors were significantly associated with lower LDL levels in female cases. So going on to, we're going to leave genetics and go and look at biomarkers. So what do we know are new in biomarkers? So this particular abstract is going to focus on SLE and metabolic syndrome. So we also know, just like in RA, SLE has an increased risk of cardiovascular disease compared to general population. And we also know that there's both traditional risk factors, such as hypertension, dyslipidemia, as well as metabolic syndrome as a risk for contributing to increased cardiovascular risk. So the purpose of this abstract was to look at subclinical atherosclerosis and the potential role of biomarkers, vascular endothelial cell activation markers, and adipocytokines in patients with and without metabolic syndrome. So they had 82 females here, 35 with metabolic syndrome, 47 without, compared with 28 controls. And the SLE patients had no prior history of cardiovascular disease to date. The results of this showed that the IMT values were higher in SLE patients compared to healthy controls. In addition, those biomarkers that we talked about, CRP, intracellular adhesion molecules, and leptin levels were higher in SLE patients than in healthy controls. So when we separated SLE into metabolic group and the non-metabolic group, we saw that the metabolic group definitely had higher IMTs as well as higher CRPs and leptin levels. They also did a subset analysis in premenopausal women were also analyzed, and once again, IMT values were also higher than healthy controls, and leptin levels were also higher. So in premenopausal women, the metabolic syndrome did not do as well with higher IMT levels and leptin levels. So in conclusion, this abstract really highlights the importance of investigating metabolic syndrome in patients with SLE. We know in the general population this has already been known as a risk factor. We also can correlate some biomarkers that they tested, such as leptin, was increased in patients with metabolic syndrome, and also correlated with IMT, which is a surrogate marker for atherosclerosis, suggesting that there's a relationship with subclinical atherosclerosis. The longitudinal follow-up of these patients and biomarkers may help to facilitate the prevention of overt cardiovascular disease and SLE. And in the subset of premenopausal women with SLE without a history of cardiovascular disease, IMT levels were also found to be increased and also related to metabolic syndrome. So now lastly in this group, we're going to look at body weight. So does body weight also have any additional contributions to cardiovascular events? We're going to look specifically at SLE patients. We know that elevated BMI is associated with cardiovascular disease in the general population. Yet, despite the high burden of cardiovascular disease in SLE patients, what is the relationship between BMI and cardiovascular outcomes? So here they use the effect of BMI on cardiovascular events in a cohort of 2,000 patients. The rate of cardiovascular events were determined in 5 different categories. So they looked at low BMI, normal BMI, overweight, obese, and severely obese was how they separated them. The cardiovascular events was defined as stroke, MI, incident angina, CABG, or claudication. And once again, these are very important for us to remember that cardiovascular events, can mean very varied definition, and we do have to really realize, do they mean just MI or do they mean a composite of stroke, MI, angina, as they're doing here in this trial. So what they found was 140 cardiovascular events were observed over 11,000 patient years, and the rate of cardiovascular events in obese patients was statistically higher compared to patients with normal weight in both the non-adjusted. After adjustment, it approached statistical significance but did not exactly meet. And here you see a chart highlighting the 5 different BMI categories that we spoke about, looking at the adjusted and the unadjusted and adjusted models, as you see here. And in conclusion, it showed that obesity that was defined between 30 and 34 was associated with the highest rate of adverse cardiovascular event. So this wasn't necessarily the highest level of BMI, but rather the second to highest level. And interestingly, the severe level, the one that was highest, greater than 35, was lower than in the overweight and obese. So this represents that unique obesity paradox, which is not a linear association, meaning not necessarily the higher your BMI, you automatically get more cardiovascular events, but there's actually a threshold where you're in the BMI of 30 to 34 has the highest compared to the other categories. So the last set of abstracts are going to highlight how do we predict future risks. So now we talked a lot about what we're looking at behind mechanisms, but what is it that we can do moving forward as clinicians to really know which patients with RA or SLE are going to be the ones that will suffer a cardiac event, and how can we find them earlier to prevent any event? So the next slide, once again, is looking at the CARE study. We had talked about that earlier, looking at sustained remission. Now we're going to look at improving the accuracy of cardiovascular risk prediction. So we know now that I told you that traditional risk factors such as hypertension or diabetes don't fully explain the increased cardiovascular risk, and that predictions for future cardiovascular disease in RA by cardiovascular risk estimates, such as the Framingham and Reynolds that we've all heard about, have demonstrated to be inadequate in certain studies. So this study wanted to highlight whether future cardiovascular disease prediction could be improved by looking at other things, looking at RA-specific factors, looking at other surrogates, or a combination of some of these. So they had the 10-year incident rate of cardiovascular disease was already determined in this prospective cohort of 353 RA patients that I spoke about earlier. And they looked at cardiovascular risk factors, RA-related risk factors, and surrogate markers. So they were looking at predictive models in separate variables, or maybe a combination of these variables that could be studied to have a better prediction for RA patients. So here we see that after 10 years of follow-up, there are 58 events in over 2,361 patient years follow-up. The cardiovascular disease incidence was about 16.4%, While if you looked at the same estimates looking at the score or the Framingham, it underestimated their risk in the same cohort is either 5.9% or 13% respectively. So clearly looking at more markers or more RA-specific and cardiovascular events do look like they correlate with a higher prediction in this group. So looking at the ROC curves that you see in front of you for the prediction of cardiovascular disease using a model that consisted of all these different factors that we talked about. So in comparison, in the graph to the right, you see cardiovascular disease and 10-year risk estimates, looking at the SCORE method, looking at the Framingham study. So this really highlights to us that the current cardiovascular risk predictions may not be as accurate as we had hoped when utilized in our population. So these authors came to the conclusion that maybe a combined model of demographic factors, cardiovascular risk factors, as well as disease-specific RA factors may more accurately predict the risk. And future studies should take a look at these findings and consider whether modification or of the pre-existing risk models will improve our assessment in our patients. So lastly, looking at SLE, how else can their cardiovascular risk equation also be helpful? So once again, going on the same theme that there is under-recognition, under-treatment of our patients, maybe due to the fact that traditional risk equations like Framingham, Reynolds, and scores don't consistently predict our risk. So the purpose here was to look at data-driven risk equations in SLE patients for cardiovascular risk. So to derive their score, risk factors were calculated based on a bunch of variables. In addition to traditional factors, they also looked at disease activity scores as well, and the formula to calculate the risk of cardiovascular events within the next 10 years was calculated. So here they looked at over 1,300 SLE patients, 93% were females, 109 cardiovascular events were found here, and you see here in Table 1, it shows the estimates of the associations between predictors and the risk of cardiovascular events. And what they see here is really a data-driven SLE cardiovascular risk score that can better estimate the 10-year risk compared to the Framingham equation, for example. And it may lead to more appropriate use of imaging and intervention. So instead of really looking at everybody with SLE and RA, that maybe we can better risk stratify who's at higher risk. And here in this graph, you see the estimated 10-year risk based on their formula versus the estimated risk based on the Framingham formula. So in conclusion, I just want to summarize. There was a lot of data we went through. We wanted to review the updates of the ACR 2012 in regards to accelerated atherosclerosis in RA and SLE. We have now experience with larger cohorts as well as some prospective cohorts that make a little bit stronger conclusions of what is going on with our patients that are not only treated with biologics but following them prospectively. We also discussed the influence of different risk stratifications within our disease activities. So in RA, we looked at ACPA status and we looked at genetic markers. In SLE, we looked at biomarkers as well as the influence of obesity and BMI. And it's important to note that there have been a lot looking at how best to measure BMI, and perhaps BMI might not be the best measure. Of course, these were used in these abstracts, but we also know that other researchers in the area are looking at lean body mass and really what your true body weight is and the influence of that moving forward for cardiovascular risk. And finally, we also reviewed the need for more accurate risk prediction in our patient population, and that the current risk equations such as Framingham and SCORE that is used in the general population might not accurately reflect in our population our risk, and more study needs to be done. So I hope you enjoyed this version of Cardiovascular Aspects in RA and SLE. I look forward to speaking to you again in future Rheumatology Highlight Reports. Thank you for your attention.